You are at a MyHIN stakeholder engagement workshop, and today is March 16th. Thank you for being here. This is session one of 3 sessions. Next slide, please. Next slide.
Sorry, 1 second. My toolbar started covering the spot to click over. There we go. Sorry, Joanne.
Yay. Okay, so this is number 1. Number 2 is April 10th. Number 3 is May 10th. So please mark your calendars now. We are building this to build on it. Basically, we would love to see engagement all the way through, and the learnings from one will move into the others. So here are the dates for the next. Be there or be square. Next slide, please. This is what's happening today. We are going to do a quick who is MyHIN? Like, what do we even do? Why are we even doing this? And clarifying, the goal of this meeting and making sure that you get out of it what you want to get out of it too. We will be going over the current state of advanced care planning in Michigan and nationally. We'll be talking and referencing some national literature. We're going to talk about what success looks like in the state of Michigan and what everybody wants to walk away with. I would say that, I'm not leading the whole thing. I'm going to hand you over. Don't get too excited. But I think if you're so moved and you need to say something, come off mute and let's do it, right? I mean, like, or you could raise your hand, but like, who can see hands? I don't know. Or put it in the chat. Interrupt me and my colleagues. I'm giving you the green light. Next slide, please. Oh, more. I don't know. This is too much. My name is Joanne Jarvie. I am the Senior Director of Outreach and Market Communications for MyHIN. Think of me as your connector. Think of me, if you want to find out what's going on, write me an email. I'll figure it out. You want to figure out who at MyHIN you should be working with on something and you don't know where to start, write to me. I'll figure it out. Maybe you've been to some of our downloads or some of our bits and bytes. Maybe you have been to some of our other standing stakeholder meetings. I run those. I try and make it so that people feel comfortable and so that we can learn from them. And I'll just take you quickly into sort of a history of MyHIN and who we are and what we do and why before I hand it over. So MyHIN, what's MyHIN? So MyHIN is the state designated entity for health information exchange. We exist separately from the state of Michigan, from health payers, from hospitals and health systems, from providers, from clinics, from other care services, but we exist to serve all of them. We are collaboratively governed. We are a network. We have a network of participating entities that have agreed to share certain amount of information and use our pipes to do so. We don't create any of our own data. We are a neutral steward of data. The data passes through. Use our pipes. They are here. Next slide. Right. So, why do we do this? Why do health information exchanges exist? Well, we are, like I said, we are a neutral data steward. And in that role, we are meant to act on the possibility, the opportunity of sharing data to make people better and to make systems better. We are also there to protect our stakeholders, to protect our human beings, to protect their privacy, to protect our systems. And we are also there to make sure that there is collaboration, that no one part of any sector is pulling more than the others. We shall work together as an ecosystem. And, we are going to talk today about our role technically, and I want you also to think about our role sort of like within human infrastructure. So there's technical infrastructure, and those are our pipes. but how people use the pipes and for what purpose and to what end. Our mission is to transform healthcare. It's to see positive change. And to me, the harder work, I think, is human infrastructure. But certainly we are here to serve in a technical role. We have found over the years that this work moves at the speed of trust, that, data, we've gotten a lot of data to flow. And if you don't know about that, let's do a MyHIN 101. We've got about 7 billion messages flowing through our pipes. And now we're sort of growing up, we're in our teenage years of health information exchange, and we are trying to make sure that that our work goes past the transaction and moves into the transformation, moves into the impact. And impact and transformation will happen at the speed of trust. That is just the problem with human beings, and also the beauty of human beings. And I think when we think about what we do, we're constantly asking why. What are we trying to communicate? Why do we want to send this data? Who does it help? What is the value and for who? And remember that sometimes just sharing data is not actually communication. Certainly communication involves a sender and a receiver, but the reasons for, a successful communication doesn't just happen in the transmission of the message. Next slide, please. Health information exchange. We want to reduce inefficiencies. We want to improve healthcare access. We want to lower healthcare costs. We want better quality of care, better health outcomes, and more, even to see if we can get even more personalized in people's care structures. And we believe that we can do this through the private, legal, meaningful sharing of electronic information. Next slide. Who do we do this for and with? Well, there's sort of 3 tiers. And we see MyHIN acting as the pipes in between, the sort of interoperability mesh. We work with federal and state governments, health departments, health payers, PIHPs, health systems, and then move down into the hospitals and the clinics and the CMHs and the FQHCs and the pharmacies, and then move down further to the point of care through doctors, nurses, clinicians, care managers, social workers. That is the ideal. That is the ideal, that at every part of this sort of journey, our stakeholders are seeing value in what they are getting through our pipes. And we do this at scale. We will have probably 10 billion messages at the end of next year. Every year, we exchange around 7.5 million admit discharge transfer notices. We've got 2 million labs flowing in. This is like big stuff. It's statewide. And if you want to know about our data flows, keep coming back. We'll get you. But when you think about MyHIN, this is what we do and for whom. And I want you to keep thinking about it as we go forward with this specific conversation. Next slide, please. This is just a how. This is like, we did the why for who. This is the how. The idea is that people connect once instead of having to build connections to every other entity, right? So instead of the mess, there's not a mess. And there's a trusted, collaboratively governed entity whose mission is to be a neutral data of steward in the middle to help out. Next slide. What does an HIE do? Okay, so we often talk about the goals of HIE. And when we say, better health outcomes, we are talking about like the sharing of information for care coordination. The sharing of information, real-time information for human beings to be able to use to make the best decisions about care for their patients. And so that's one level of it. And then, of course, when you look at large groups of data, you can also see things about populations, right? You can also start to see patterns. And so if a lot of people in Michigan start going to the hospital because there's an outbreak, our system will be able to show you that. But most importantly, and now since we have so much data flowing and that big data capture is really is able to happen, we're really focusing in on the meaningful information for doctors and their patients, and trying to make sure that the data that we exchange, the information that we exchange, is truly integrated into a clinical workflow. And guess what? We're not doctors. I mean, I feel like maybe, come work, maybe we should just have doctors here. But we have all these people that are building, and we need clinicians to share. We need our stakeholders to tell us how they work and how they want to work and what they need information for, and if we can get it for them legally. We don't have the answers. We have the technology to support what you need. And what your patients need at any one point in their care journey. Next slide. I have the real pleasure of working with, first of all, everybody that I work with, I really, really like, but I especially like these people. And these are the people who are going to take you through the workshops. These are the people that are going to listen for what it is you need to use information for, and what information you need to make people feel better. We have Lisa Nicolau, who is the director of our cross-sector data sharing program, which was our SDOH program, but that's not the right name. We are really tasked with understanding how to move data across sectors, from data from where it starts to where it should be, even if that's crossing sectors. We have Lauren, who is working on our slides today and watching the chats. She is a project manager. Van, who is a product marketing manager. He's like one of those technical guys, but he speaks in English, so it's fine. Like, he can talk like a regular person. He's not going to get too technical. And then, of course, Monica, who has been our Making Choices Michigan program manager. And we'll learn a little bit more about that through these workshops. Next slide. I think now I'm going to pass it over to Lisa Nicolau, the director of our cross-sector data sharing program, who has red hair and is Canadian. If you have any questions for me, I'm going to put my email in the chat, and you can always write me, ask me what's going on. I'll tell you everything. Well, everything that I know, which is, enough to be dangerous. Thank you. And please come back.
Well, hi there. Very good. Thank you guys for joining us on a Thursday afternoon. I'm grateful to see so many folks joining us and taking an interest in this. So we will hopefully delve into some really good discussions here. I'm wondering if we do have a poll, if we could allow 3 or 4 minutes to for everybody to just quickly take a poll. We want to understand kind of the state of things. So if you don't mind, go ahead. I think the poll is up and live. If you want to take a moment to go ahead and answer a few questions, I would greatly appreciate it.
Here's the data we need to measure change, folks. We need to make sure that we're moving the needle and that you get value. And in case you could write us every day and tell us how great you think it was, or we could just do these polls, or I could survey you every day for the rest of your life.
Careful, she's not joking. Once we kind of get up there, we'll move on. We're up to 65%. Super grateful for that.
It's stalled. The rest may be mine.
Maybe. Nope. It keeps going. It keeps going. We're up to
Oh,
70%, people.
so exciting.
So exciting. I'm with you. I love seeing things kind of actually function. So we'll give it another minute here. Seeing a whole lot change. All right. My team, do you think we can pull that down? I haven't seen it change in a little bit. And just, while everybody's finishing this off, I'm going to reiterate what Joanne said, which is, you know, the value of these sessions is really in understanding your perspective, not from us standing up here, you know, spouting off. It's really in the discussion and really trying to understand things from the widest perspective. So I will encourage everybody to just jump off mute. I am a people person. Join us on camera if you want to, and really kind of weigh in. So at any point along the way, if you have a comment, join the conversation. My team, I think that we can probably pull the poll down. I have not seen that change one bit in the last minute or so. So we were able to get up to, yeah, can we share the results of this? Caitlin, if you want to weigh in, if we can share the results. Can everybody see the results?
Hey, I clicked share, so are you guys not seeing it?
Yep, we
Yeah.
are.
Yep.
Seeing
it. Yes, we are seeing it.
Okay, I don't know what other people can see, so I'm probably like the least qualified host here. All right, so we were really looking at to understand what the current state of advanced care planning and understanding who's very familiar or slightly familiar. So we have 15% of people who are very familiar, 38% moderately familiar, 41% slightly familiar, and some not familiar at all, which is perfect. Next, we are on to kind of what's the current state of advanced care planning nationally, which seems to be changing, and that's kind of part of what the drivers were for these sessions. So 12% very familiar, 26% moderately familiar, 38% slightly familiar, and 24% not familiar at all. So hopefully we can have a conversation. The familiarity with MyHIN, 32% very familiar, 35% moderately, 29% slightly, and 3% not familiar at all. And then what MyHIN does as it relates to advanced care planning, 9% very familiar, 26% moderately, 44% slightly, and 21% not familiar at all. So hopefully we can try to provide a better level set as to where we are. All right, I'm going to close that poll. Or actually, maybe I'm not going to. Somebody else is going to. Caitlin, can
everyone?
There we go.
Yeah, I would say
Did
close
it
that right
disappear? Okay, very good. All right, so again, I'm going to just reiterate. My name's Lisa Nicolaou. My background is that I am a nurse. I got really tired of running into brick walls every time I turned around, whether that was in the clinical environment or in an administrative environment. I kept feeling like data is the answer. Data has to be how we get to an effective healthcare system to really understand kind of what drives good quality care. So I went on to do a master's in information science, and one thing led to the other. After transformation demonstrations within the state of Michigan, we ended up, all things led to MyHIN. That's what ended up here, how I ended up here. In terms of my advanced care planning journey, I did work with advanced care planning in the Traverse City region. and really struggled for years to be able to get advanced care planning off the ground. So it's a passion. It's something that I believe in, and the value of conversations as we approach serious illness really is a big deal. When I came to MyHIN, and when I took over the advanced care planning conversation, it really kind of came to light that there were some changes coming on nationally. So we really wanted to understand what the trajectory was for MyHIN within this space, to really make sure that we're paying attention to the information that is out there to help guide, strategically guide what the next steps are for MyHIN and the technology within Michigan. So the purpose of these three different convenings is really to level set on the current state of Michigan and the national environment, and to really understand what that current national literature on advanced care planning outcomes is. I know that we sent out some national literature. I think everybody was like, hey, what do you mean? Just a quick show of hands, thumbs up, thumbs down. Did you get to read any of that or watch any of the videos or? Seeing a couple of thumbs up. Good. They are there. I would strongly encourage folks to take a look at it. I know for myself, it was an eye-opening experience. So the purpose of this specific session is to do that level set, to get us all on the same page, to really understand the state of things, and then to use some facilitated discussion across those broad stakeholder groups to really come forward with recommendations on what does success in this space look like for Michigan. In part, not so much that we're gonna, make that all happen, but to really start us thinking along the lines of what is it that we want to see happen out of this. How do we measure it? All of those good things. What metrics, shorter term, longer term, could we use to be able to measure progress towards that success? What is available in the state of Michigan currently for advanced care planning, conversation, training, leadership, and collaboration, as well as those individual advanced care planning conversations? What information, what data is most important to move between those care environments to support those serious illness conversations and care planning? And then are there any, and understanding from your perspective of what policy barriers, if there are policy barriers that create a need for technical workarounds. Next slide. I think there's a little plug here again for there's the date. Can we drop, it may already be there, can we drop the registration link into the chat for this? I would strongly encourage, this is really just a level set. The meat and the potatoes really comes the next two sessions. So I would encourage you to do your own research on this and come prepared to have those really intense conversations across a wide group of stakeholders.
Kate, I didn't want to interrupt you. I know you did say, this is Tracy from Covenant Healthcare. I know you did say that you guys wanted to help with the presentation. So just curious a little bit, did you want to talk more about the articles and video that was shared?
I think that as we go through it, we will start to talk about that. Yes.
Okay.
Feel free to come off mute anytime. Thank you for jumping in. All right, next slide. So in terms of the Michigan landscape, training and education. So I tried to break this down from all of these different concepts. So what exists right now within the space, and kind of how did we get here? So from 1990 to 2000, there was a national movement in advanced care planning. It was a hot button topic, and it all seemed to make so much sense. If we could only engage people in conversations earlier in the space, starting as early as need be, to understand what they might want, then we could actually make their wishes happen at the end of life. Makes great sense. There's been an evolution of the documents that happens, or there's a little confusion surrounding kind of what is a legal document, what isn't a legal document. It does take some information to really get there. And how that information has been captured has evolved over the course of that decade, actually the last 2 decades. Advanced care planning efforts were really promoted as key drivers for patient autonomy at the end of life and to help save on that unwanted care and lead to better outcomes, lower cost of care. Certainly, you know, I think everything that we try to do is a desire to lower the cost of care. But that was really the push. That was how it was sold. The Respecting Choices model is really a copyrighted systematic program licensed by Gunderson Healthcare System. And it was initiated in 1991. It was adopted through Great Lakes Health Connect, which was another HIE within the state of Michigan that was ultimately brought into MyHIN when MyHIN and Great Lakes Health Connect merged. That was adopted as a strategic business unit within here. But Respecting Choices was a predominant model that really came through. That model really has an extensive network of training and facilitation providers. There's different models of system or different models of care in the state now. Different systems, different healthcare systems have invested in different solutions, and that's great. That shows that there's maybe not just one way of doing these things. Certainly, physicians have been doing these serious illness conversations for a long time. So it doesn't need to be a specific model of training, but recognizing that there are different models that are floating throughout the environment. There does not seem to be, and I would love when we get down to kind of conversations on this in the breakout rooms to really make sure that I'm correct in that assumption. There are not really many sources of free training that really exist within the environment. Next slide. And then what role does MyHIN have in this? So as I said before, we have something called Making Choices Michigan. Making Choices Michigan was initially developed through Great Lakes Health Connect between 2017 and 2019. Operated through Great Lakes Health Connect between 2017 and 2019, but it started back in 2010. In 2020, when Great Lakes Health Connect and MyHIN merged, it was adopted. Continues on with a very specific model on respecting choices. And that Making Choices Michigan really promotes advanced care planning conversations and process in healthcare and community. It's focused on leadership and convening, training, as well as individual engagement. Between 2020 and 2022, that program trained 66 people from 24 organizations across the Midwest. It developed an advanced care planning leaders and coordinators group during the COVID-19 pandemic. And it maintains a system of volunteers to conduct advanced care planning conversations within the community. So that's one aspect of the work that MyHIN does within training and facilitation. Questions, comments, thoughts about that? Before we move on, I want to make sure that we're opening up the conversation. All right, next slide. How about payment model support? Within Michigan, advanced care planning efforts are promoted as a key driver for patient autonomy at the end of life. Again, goals of saving for unwanted care, leading to better outcomes at the end of life, as well as lower costs. We've been blessed to have advanced care planning conversations financially supported both through public and private payers. And I don't believe, though, advanced care planning conversations are not financially supported through Medicaid health plans, despite payment support for conversations. Our engagement in advanced care planning conversations estimates still are fairly low at 7.5%. It's important to note that advanced care planning conversations and the financial payment and the reimbursement is for the conversation itself. not required to have those documents in order to bill for conversation. Is there anybody from payers here who wants to add in to jump into that? Any other thoughts? Have I got it right? I see Diane Marriott here. Anything to add, Diane? Because you know I like to pick on people. Tori Fields, hi. How are you?
Hi.
Tori, do you want to take a minute to introduce yourself? Tori's an excellent source here.
Hi, I'm Tori Fields. I'm a health services researcher and a health economist, and have worked across the country looking at payment models and programs and policy that affects people with serious illness, and was able to be part of some of the early conversations about the advanced care planning billing codes, and some of the most recent analysis of how that's working out to date. The one thing to note, I think, is also that there are some requirements on that bottom bullet. When in 2022, advanced care planning became a HEDIS code or a HEDIS measure for a specific subset of payers. And so for those who are supporting dual eligible populations, that is a HEDIS measure. And so in the new HEDIS documentation, there are some new requirements that actually do have some matching components to get to a little bit of this bottom bullet, but it's not a requirement for any of the other payers, as you were saying. So it's not a requirement for the duals plans, though you could select it, and it's not a requirement for any of the other payers.
Great. Thank you so much for jumping in. Tori is just a great source of knowledge on this. Anybody else? Let's move on. Next slide.
Lisa, there was a question in the chat asking how recent is the 7.5% data?
I would have to go back to my source. It's in the literature that was sent out. I want to say most of the literature that we sent out was within the last 3 years. We tried to find the absolute most recent information. Advanced care planning documents. And I have to say, I had to clear out the cobwebs and kind of come back to it and really get my education. And I thank all of those facilitators and the experts in this who helped to clarify my understanding of this. So first and foremost, the advanced care planning documents, a patient advocate designation. I always called it a durable power of attorney for healthcare, but I have been told that the right term is patient advocate designation. This is a legal document. It identifies a surrogate decision maker, and it's intended to not just identify, but provide contact information for. So if there was one thing that I have heard, is that this is the critical document to be able for clinicians to be able to engage in conversations with the right people. This document requires patient signature in front of 2 witnesses. It requires that the advocate must also sign the acceptance of this role. The witnesses must sign. There are some other aspects of the documentation that really kind of goes on to focus on treatment preferences. These are optional portions. The document itself, though, the patient advocate designation is the real meat and potatoes of it. The other documents, or the other portion of these optional documents, really kind of get into a variety of different formats, different templates with varying content that can be filled out, and it can be just as much as a check mark. The content of these documents may lack relevancy for clinicians to guide the conversations as the individual condition changes. One physician that I did engage with specifically stated that the specificity of the situations that are described in that document really are so specific that it really does never account for the right situation to really have a meaningful conversation. It's really, it's not as beneficial in their eyes. But that's just a couple of physicians. So I think that there may be a potential for a wider discussion of physician preferences. There are out of hospital medical orders. One is the MyPost document. And I know that there has been a recent uptake of MyPost here within Michigan. I'm hoping there's some MyPost people on there, but this is really physician orders for life-sustaining treatment. It really directs CPR preferences and additional selected medical interventions. And then there's a DNR order, and it directs the withholding of CPR. These documents may be intended to change as the individual's condition changes over time. It's an advisory only within a hospital. So it is not, once the patient gets to the hospital, those documents are advisory only. The only legal document is the patient advocate designation. Anybody want to correct me? Because I can guarantee you somebody's got something to say. Have I got it right?
Hi,
Wrong?
Lisa. Lisa,
Yeah.
this is Amy. Can you hear me?
And
So the MyPost is the Michigan Physician Orders for Scope of Treatment.
scope of treatment. There we go.
Yep.
Thank you.
And that one is only good for 12 months, whereas the out-of-hospital DNR order does not have an expiration date, but may be revoked.
Great. Is it is the comment about that MyPost documents are intended to change as an individual's condition changes? Is that correct? Is that a correct assumption? I'm digging back here.
Yes, yeah, I would say yes, because the patient or the patient advocate or legal guardian must reaffirm the document as the levels of care changes or as the patient's condition changes. Yes,
Sure.
you've got that.
Okay.
And Lisa,
Yeah.
this is Diane. I am sorry to interrupt. I couldn't get myself off of mute. So
No worries.
my apologies, but just I wrote it in the chat, but as you referenced earlier, though, Medicaid coverage is on a journey towards it, Medicare does cover ACP, and it was a requirement of the CPC Plus demo and the PCF demo. Our commercial payers also have coverage for ACP. And I can get back with you on more specifics of that later with the payers if it's helpful. I'm sorry to jump in, but
No,
I was so excited to figure out how to unmute myself. I couldn't contain the enthusiasm. So
You know me, I appreciate it when people jump in because then I can get to go silent for a little bit. So thank you for jumping in. Amy, thank you for that clarification. I remember being a nurse, and we used to write some of these documents in pencil because they were intended to change as that individual's condition changed. So I'm glad to see that those are here and up and moving. And I know that there's a committee that is working on kind of expanding access and really kind of rolling it out and making it prevalent here in the state. So bravo. Next slide. So I'm gonna allow Van Lee to come into this because Van is the man who manages our advanced care planning document exchange use case. Van, do you want to join me?
Yeah, it'd be my pleasure. Good afternoon, everyone. So a little background before I get into the use case. I've been with MyHIN for 3 years now, and in the healthcare sector for over 11 years now, most of which were spent working directly with physicians and their staff to meet some of the newer requirements that came from CMS, such as an incentive program called Meaningful Use, and that paid providers to switch to an electronic health record system. And there were penalties also for not providing high quality care for their Medicare patients. And of course, and thank you, Tori, for getting off mute, and Diane earlier, you mentioned that some of those programs tied to a measurement, and that was advanced care planning or ACP. So that was actually my first exposure really to this work way back then. So in the context of MyHIN, the ACP exchange use case is one of our many use cases here at MyHIN. It enables the exchange and sharing of submitted advanced directives and other ACP-related documents to support treatment, payment, and healthcare operations. This vision was driven by our state's Health Information Technology Commission, or the HIT Commission, which identified a need for a centralized ACP electronic repository operated by MyHIN, the statewide exchange. As common with our other use cases, we do not limit participation based on vendor name, but on vendor capabilities, therefore being vendor agnostic. For example, in our clinical exchange use cases where we share hospital information, we're not saying that only Epic or Cerner hospitals can participate, right? That would not meet the goals of our use case. So similar here, we'll work with your AD vendor or our participants' AD vendor. A predecessor to exchanging this information in this use case is actually having the technical ability to query, retrieve, and display those retrieved documents in our MyGateway tool, which our network providers or participants use to access the clinical information that's exchanged in MyHIN. We've actually partnered with a vendor named AD Vault in Michigan as our HITRUST certified repository, replacing our legacy or previously used patient care document upload tool. And we've also built that ability to query and retrieve with AD Vault to be able to access those advanced care planning documents, and again, be shared within our network. We here understand that there are multiple ACP document repositories with amazing next generation consumer friendly tools and apps that I'm quite frankly impressed by. So this use case really aims to embrace that, but also use that same technology I mentioned before for query and retrieving to connect with those other ACP vendors that are in use in Michigan. Now, it's important to note there are no requirements or regulations called out in our use case that requires all vendors to participate. Also, vendors may not want to connect with us. So just because we have this use case does not mean that we're connected to everyone, for example, in a month or so. It's really based on our participants and our participants' need for exchanging advanced care plan documents. Next slide, please. All right, so today MyHIN has access to 606 advanced directives in our exchange, 70 of which are durable power of attorney documents. The remaining directives are DNRs, pulse documents, medical power of attorney documents, and living wills. From a query perspective, we've asked AD Vault the number of times a user has queried for advanced directives. For Michigan source directives, and it's approximately 12,000 times a year. And I'm actually going to pass it now back to Lisa, I think on the next slide, to go back and talk about some of the national trends.
Sure. And I think whoever had mentioned, can we get into the conversation about kind of what's happening at a national level? We've kind of been at this advanced care planning stuff for about 20 years now. Which is good. We have 20 years worth of data. So some of the national trends that we're seeing in the literature, and we'll go a little bit further into the literature here in a bit, but serious discussions about the validity of the current processes and tools, which outline serious illness conversations. So the idea that someone can extrapolate, can make choices when they are not faced, and be able to say, if you were sick, what would you do? It's been really shown that is not something that people are capable of doing. So the time and energy and effort into documenting those choices in a very specific way may not be as beneficial. There's some important, it's most important to really understand that patient advocate designation and the contact information so that that individual's trusted representative can be contacted. Additional focus by clinicians to understand what is meaningful and valuable to a person with serious illness. It starts a different starting point for the point of care conversation, which is really what is emerging as the most important thing. Recognizing inclusion criteria or for inclusion in palliative or hospice care earlier than in other illness progressions. or earlier in the illness progression. So that is really being highlighted as the need to really help honor people's wishes. And questioning those opportunity costs. If we're spending a lot of time, and again, the entire nation went down this pathway, if this is really not kind of helping us, then what are the opportunities that we're missing out on to engage in? Next slide. So everybody's, if you're in healthcare, you understand about quality improvement, right? Quality improvement really seeks to standardize processes and structures to reduce variation and achieve predictable results to improve those outcomes for patients. And that is done through data. Plan, do, study, act is the quality improvement process. We planned, we did, we've studied, and now it's time for us to act. So again, next slide, we have 20 years worth of data to drive some of the decision making that we have before us now. So many high quality studies, and again, we'll take some snippets of what that national literature is pointing to, but I would encourage each and every one of you to read some of it, to listen to the video, to really understand the state of things as you come to the next two sessions. Lots of high quality studies, systematic literature reviews based over many decades of research, randomized controlled studies. We're not talking, it's high quality data. And it's really, as a state, up to us, and again, as from our lens, from MyHIN's lens, we want to make the best use of health information technology dollars that we can. We want to understand from your perspective, based on national literature, what direction do we need to go in? How should processes, documents, conversations, and information movement be changed to support illness conversations? That's what we are here to wrap our arms around and hear from you. Next slide. So national literature. Research and outcomes are being brought into question. Lots of large studies. Advanced care planning fails to improve end-of-life care. There's no association of advanced care planning with subsequent healthcare use, including emergency department visits, hospitalizations, and critical care. And not that I personally, I don't necessarily believe that that's really well-matched outcomes, but that's kind of what we were given. That's what we were told it was going to do. I think there's some rethinking of that. Where does that fit in? Could not identify meaningful differences in healthcare use, patient quality of life, or goal concordant care between those randomly assigned to receive either advanced care planning or usual care. So some of the national literature is really saying it's a focus on serious illness conversations and training of clinicians to initiate these conversations earlier in the disease process that is really the important work ahead. Next slide. This one really struck me. The whole notion of advanced care planning ignores the reality that we can't anticipate our future ability to adjust and accept constraints on our life that at an earlier stage of life we would have seemed unacceptable. Meaning, if you're healthy and you have no context for that serious illness conversation, taking the time to do that in advance may not result in different, in the same decisions being made. So the idea of adhering to people's wishes seems like that's not possible. Next slide. The focus of advanced care planning should be on preparing both the patient and the surrogate for medical decision-making made by focusing on what the quality of life means to the individual. And that gets down to kind of some of the work that's gone on to create better capture tools to understand what those values might be. Next slide. The inability of advanced care planning to achieve its desired outcome represents the gap between hypothetical scenarios and decision-making processes in clinical practice settings. I'm going to stop because I know that there are a lot. Actually, if there's one more, keep going. We may as well get them all out of the way here. Scenarios and situations in clinical practice settings rarely reflect these conditions. Treatment choices near the end of life are not simple, consistent, logical, linear, or predictable, but are complex, uncertain, emotionally laden, and fluid. Amy, jump in.
Thank you, Lisa. I have to share with you, I struggle when we talk about national literature because Michigan is one of 3 states that does not recognize a living will. And to me, a lot of the national literature is focusing on advanced care planning documents that are living wills that say, here are my preferences for care medical team. This is what you may or may not do to me. Excuse me. And so, but yet in our state, we focus on a patient advocate. And so we are following our patients' wishes in Michigan when they've created this document because we are talking to the patient advocate. But then that leaves open the whole, did the patient advocate even talk to their, or did the patient even talk to the patient advocate about their health? So I just wanted to reflect on that because I do training to help people facilitate these conversations, and a lot of people don't, and a lot of our medical teams don't realize that living wills are not recognized in the state of Michigan. So I just had to share that. Thank you.
That's a great point to bring up when we start talking about policy, to understand kind of what some of those policy barriers are that that help drive some of it. When you talk about when we talk about the national literature and the national conversation, it's always going to be important to like make internal decisions here within Michigan. And that's kind of not that we are a decision-making body, but we can certainly convene people, we can understand kind of the perspectives, and we can raise the right issues. Anybody else want to make a comment?
This is
Yeah,
Tracy.
Okay.
Go ahead.
So I've been before I switched into my name's Trudy, and before I switched into administration with Blue Cross, I was a social worker for 20 years, and I worked in hospice, palliative care, community chronic disease management, and I can say I'm finally excited that what I've known to be true as a clinician is demonstrated in the video and in the literature that was shared. I am thankful, like what Amy said, that we are a state that focuses on that patient advocate piece, because those are the folks that are making the decisions. But one of the things that I've always struggled with is that we are a culture that has a challenge having those difficult conversations in advance with the families. It should be the families that are having the conversations with shared decision making with the doctor, not just filling out a bunch of check boxes.
Yeah. Great comment.
I just want to agree with a little bit of what Amy and Trudy shared. Reading through the literature at first, I just briefed it, and I was thinking, oh my gosh, everything that I've supported is not supported in this literature. But then when I really took a deep dive into it, we are in fact doing just exactly that the national articles recommend, which is that patient advocate designation. So I just want to point that out and caution anybody that will look at the articles. Please don't do a quick read, because you may be misled like I was, thinking maybe this data is showing that our ACP work isn't valuable. But truly, Michigan has been following the recommendations from the national data.
Again, the advanced care planning conversations themselves are spectacular. They, understanding who that patient advocate is, it's how do we and what do we choose to do? And again, from our lens, we are looking at what data needs to move interoperably throughout the environment to support that the end of serious illness conversation. Next slide. So I know that we wanted to take a quick 5-minute break, and I think that we're kind of running a little bit behind. I think the breakout rooms will be great, and we're looking to really kind of hear and make it smaller. So I think what we're going to do is we're going to take just a quick 5-minute break. Can we reconvene at like 4:05? All right, everybody can get up, grab a quick glass of water, and and then meet back here at 4:05. Hi there, folks. How'd it go? How'd it go? I want to hear what everybody else talked about. Who wants to share some thoughts? Monica and Van, you guys were facilitating. Van, tell me what you heard.
Yeah, sure. And Tracy, you were in mid-thought there, but I hope I captured the main part of their conversation. So sorry about that. But yeah, we looked at it from that continuum that you shared. So we looked at it starting from the patient perspective, and we try to answer the question of what does success look like in Michigan from the patient, from the care team, from the provider, from the advocate, from the system perspective. And so I want to share, I think, the top 3 things that came out of that. And the first is actually a quote from Tracy here, and it's, I don't want to learn how important this was in hindsight, right? And so education was really highlighted in our work group. Success in Michigan from the patient perspective is that they understand that this is a guide, right? And that picking someone you trust as your advocate is important. There was also a discussion around this education happening further upstream from the hospital and the clinical perspective. When you think about the hospital and you're in crisis from a clinical perspective, providers want to see that discussion and all of this really handled upstream. At that moment in time, it's really difficult to start talking about where your documents are and trust that information should be perhaps handled upstream. And when we talked about upstream, we talked about the primary care office. We talked about letting primary care know that it's okay to tell your patients that these discussions can happen with social workers, that this can happen with your not just the MD level, right? And that there are other levels of care that you can have these conversations, and you don't have to just talk to them with the provider. And then, the final thing is, if I just talk about a workflow around what success looks like in Michigan, success is that I've had the discussion, that they're documented, and if I'm in crisis, they'll talk to someone and my wishes are recognized. That someone is, of course, that trusted advocate that I have, and that my wishes are recognized, right?
So can I ask a question of the group? When you were talking about that, you were talking about the conversation. You're talking about the conversation with the patient's advocate.
Yes, I think that was it.
Is that correct?
Both. but
Okay.
more the patient advocate.
Okay. Great.
Another good point that was referenced in our session was the separation of serious illness conversations versus patient advocacy designation, and starting the patient advocacy designation conversation earlier than 65, 55 plus. We got into this topic of the policy barrier of not having next of kin or family make those decisions for you, not just being able to serve as an advocate without that patient advocacy designation. So I think, having the idea of like separating those two conversations and really, making sure that that patient advocacy designation is there and recognized. I think that was a really good takeaway from
That's a great thought. Yeah. Like it. What else
Yeah.
did you hear, Monica?
There was also a good point about, upcoming policy. Amy Bailey Sheets from My Michigan Health had mentioned that there's policy coming down the line about maybe taking out the copayment portion of the wellness visit. And obviously she could probably speak to it a bit better than I can, but I just thought that that was a really cool idea if we can, eliminate the cost factor with those wellness visits and with having these conversations and eliminating the need for a referral in order to have these conversations, just really honing in on the accessibility of this. I think that that was a really, really cool thing.
Great. Did anybody have thoughts about like what it looked like from a care team perspective, or from a patient days at home, or did anybody kind of get down to what it looks like for an individual or the care team?
I'm not quite, I'm not quite clear when you say, are you talking about homebound folks or?
Well, like I think about how we, how do we identify when someone is having quality serious illness care, and understanding kind of the impact on more days in hospital, less days in hospital, more days or more emergency department visits. If we were to look on it in 30 years, what would that look like? And the same thing from like the care team perspective, thinking about somebody had mentioned about the coordination between care team members, specifically specialty care and primary care. And
well, we didn't talk about that directly, but I think kind of the talk of the town is predictive analytics, right? And in terms of like payers building predictive modeling and using claims data and looking for trends in patients, and so that how we can use that information to identify, to help payers kind of figure out, because we know that that not payers, that providers help providers figure out, so to figure out the trends, so that if we're seeing something, we can pass along that person's name and say, hey, just want to let you know we're noticing this about this patient. So for me, like I think that's where MyHen actually plays a significant role in that too, is we're sharing information, is how can we use data to help improve patients' lives and help our providers, our doctors, our nurses. Yeah, there you go, readmission risk score, but there's more than that too.
yeah,
It's not just readmission risk score anymore.
no,
So there's rising risk, emerging risk. There's a lot of literature on that, and figuring out what are the trends in people that eventually rise and spend, and how can we use that information to get ahead of the really I guess it's using data to figure out how to best implement proactive public health approaches, really.
sure.
So we didn't talk about that, but that's a good point, using it for advancing illness.
Sure. Yeah. And I think that the real goal there was to try to kind of figure out, like, currently, the storage of documents is how we measure kind of effective process here. And I'm not really sure that storing of documents is really a good, or creation of the document is necessarily the right measure, although it does seem like the creation of a patient advocate designation might be a really good understanding of success in this case.
You used to be able to tell by how thick somebody's chart was.
Exactly. Exactly.
Anymore.
Very cool. And I know from our session, I think we heard that, really understanding, there was some conversation about tool capture and kind of understanding from a clinician, a physician standpoint, who largely has to have these conversations, has to have the serious illness conversation. Again, all of the pre-lead up and everything else, but at the point of care, the person who really is put to the test and has the conversation with families and has the conversation with patient advocates and with the patients themselves are really physicians, and understanding from the physician perspective what information they need and in what format was a theme that came through. And then we had Patrick with us, who really has the unique perspective of the LGBTQ community, and how do these conversations impact and the training that is needed to have this from a culturally sensitive point of view, both for the LGBTQ community, but as well as our different races and ethnicities. So really coming down to kind of the key on training. Any other thoughts on this? So I think we're almost at time. I wanted to say thank you so much for engaging and staying with us. And I would encourage all of you to come back to the next session. I would encourage everybody to take a read through the literature to really help us, because the next couple of sessions, we're really going to get down to more nitty gritty of, you know, what do we do in this space? What is MyHIN's role in this space? What information must flow through the pipelines? And what is our strategy going forward, trying to kind of help us figure that out and invest in technology wisely. So thank you again for joining us. Our team, I think maybe we should stay on for a few minutes and just do a quick sum up, but thank you so much for joining us, and we hope we see you next time.